Good evening, everybody. Good evening. How you day? Welcome to another session of Ask the Doctors. How are you? Happy Sunday. The time is 8 p.m. Today is the 4th of June, 2023. How have you been? Welcome again. My name is Frederick Unubohai, and this is Ask the Doctors every Sunday by 8 p.m. Now, today we'll be talking about something very, very interesting. And they'll connect their mic before you can add them. Okay, sir, your mic is not connected. Your mic and your camera is not connected, sir. So I can't see you. Good evening, everybody. Welcome. I can see Philip here. I'm trying to bring you up, sir, but it's showing your mic is not connected. Victoria, good evening. Philip, how are you? Ngozi Amina, good evening. Welcome, everybody. We are streaming live on YouTube and we are streaming live on Facebook. So we're talking about prostate cancer, and we have a guest joining us today. Ngozi Amina, how are you? Good evening. Chief, your device is not connected. I don't know why. I don't know why. Good evening, everybody. Welcome. Tell me, where are you joining me from? We have about 30 people already. Angela is watching us from YouTube. Angela is watching us from YouTube. Good evening, everybody. Share this live. Where are you watching me from? Um, Dr. Israel is in the house. Dr. Israel is in the house. Dr. Israel, how you doing?
I'm
Welcome.
fine. Good evening, everybody. Happy Sunday.
Yeah, happy Sunday. Good evening, Agbesi from Deutschland. Ngozi from Deutschland. Good evening, Agbesi. Welcome. Okay, so we are discussing prostate cancer today, and our guest is trying to join us. I don't know what is happening. I don't know what is happening to his device, but I hope he'll be able to join us tonight to talk about prostate cancer. Okay. Good evening, Uchenna John. Welcome. If you have any questions on prostate cancer, please, just relax. We'll take your questions today. Good evening. Watching from Kogi State. I see you. Okay. What is going on? Okay, yes. Dr. Martins is in the house. I can see our guest already is in the house. So what I'm gonna do, let me set up his bio. I'm doing that here. I can see him. I'm setting this up. Okay. Just give me a few minutes. I'll do this. Let me introduce him without wasting our time. Okay. Okay. So let me introduce our guest. Chief, are you ready? If you are ready, just give me a sign. Okay, good. So let me introduce our guest to you this evening. Everybody, good evening. Welcome again to Ask the Doctors. My name is Dr. Fred, host. Dr. Israel here is our co-host too. So our guest tonight is Dr. Igbokwe Martins. He's a consultant urologist. He's a surgeon, a kidney transplant surgeon. Now he works in Nigeria. He works in Abuja at the Zenith Medical and Kidney Center. If you don't know, he's a fellow of the West African College of Surgeons. He's a fellow of the National Postgraduate Medical College of Nigeria. He's the head of the urology department at the Zenith Medical Center. And here he performs kidney transplant surgeries in sub-Saharan Africa with an average of about 100 cases annually. Now, this center has a robust hemodialysis unit. And I was so surprised when I got this that they have close to 50 dialysis machines. And this caters for the population of people with chronic kidney disease in Nigeria. He's a member of the Transplant Association of Nigeria. Also a member of the Nigerian Association of Urological Surgeons. He's a member of the Nigerian Cancer Society and many other international medical associations slash organizations. He's a researcher with over 40 publications in peer-reviewed national and international journals. Ladies and gentlemen, help me welcome to Ask the Doctors tonight. He has been here before, but not on this new platform. Help me welcome Dr. Martins Ibukwe. Good evening, Chief.
Good evening, Fred. Good
Good
evening,
evening,
Dr.
Chief.
Israel. It's nice to see you guys again. It's been quite some time.
Yes, so
I
yes,
am
Chief,
telling you.
it's great to have you here, sir.
My pleasure.
Ladies and gentlemen, we have an expert in the house to talk to us about prostate cancer. Now, the reason we invited him tonight was because there's been so much misinformation about prostate cancer to the point that I got tired. I don't know, maybe tired and scared. Like maybe I don't even understand prostate cancer anymore. So we brought him on this platform to talk to us about prostate cancer. So, sir, briefly, help us lay the foundation. What is prostate cancer?
All right. Thank you once again, Dr. Fred and Dr. Israel. It's always a pleasure to be on your platform to continue to educate, our people, especially Nigerian people, as regards various health conditions. So today, I'm so happy we're talking about prostate cancer. And I'm hoping that at the end of today, all the people that are listening are more educated and aware of what this disease entity is and able to clear some of the misconceptions that they have. So when we say cancer, cancer means an abnormal growth of some cells in the body, which, it's in which case these cells continue to replicate even when the body tells them to stop. So what this means is that these abnormal cells, can actually begin to cause disease conditions and can actually spread to other parts of the body and cause death. So this is not any different when we talk about prostate cancer. So what prostate cancer means is that there's an abnormal growth in the prostate gland, and this growth, goes beyond what is normal. And this has the capacity to grow beyond the prostate and outside the prostate to other parts of the body and has the capacity to kill. Prostate cancer is the commonest cancer that afflicts Black men all over the world and the commonest cause of cancer-related death in Black men. It's not the commonest cancer all over the world because there are other common cancers like lung cancer, okay, in men, and then in women, we have breast cancer and cervical cancer, okay? But among Black men, prostate cancer shoots up to number one. So this is the reason why this is even more important and more topical for us to discuss in Nigeria, where, of course, our population is 100%, made up of the Black race. So initially, we didn't know the epidemiology of this disease. We didn't know how common it was until we began to do studies in our own local environments. Hospital-based studies initially in the 80s and 90s, Osegbe et al., Badmos et al., were telling us that about 100 in 100,000 men had prostate cancer. But these were hospital-based studies. They were waiting for men to come to the hospital to know what disease they had. And then those that had cancer were surveyed. It was not until early this decade, 2001, 2002, when Ikerewe et al. In Lagos went into the population of Lagos State to check men in their homes. And we found that the incidence of prostate cancer was over 1,000, about 1,070 or thereabout in 100,000 men, which is the highest density or highest population of individuals having prostate cancer. This is not surprising because prostate cancer can be an indolent disease. It can be there without people knowing. So if you don't have a screening mechanism whereby you go into the population to find out those that are at risk, those that may have the disease, those that may have early versions of the disease, then you're not likely to pick many of the patients because he said that men can have and die with prostate cancer, die with it rather than from the disease. So you may have to look for this disease in order to find it. Otherwise, you're going to continue to have a high incidence of death from prostate cancer. So with this being said, I think people can understand when we say that 1 in 12 men, will have prostate cancer in their lives and may die of the disease. So you can see that this actually hits home. And to buttress this point, it's very likely that everybody listening to this live may have had a relative, father, uncle, grandfather, who may have suffered from prostate cancer. So it's a wonderful thing that we've decided to discuss this topic today, Dr. Fred. Thank you.
Thank you very much, sir. If you're just coming, you're welcome. We're talking about prostate cancer, and we have Dr. Martins Igbokwe to help us again on this very interesting topic. Now, he has said that about 1 in 12 men could come down with prostate cancer. Sir, could you help us? At what age? Because we're trying to make this conversation direct to these misinformations we have about prostate cancer. So, at what age should we start getting bothered or concerned about prostate cancer in a man?
Okay, so I think this is important because the peak age that we find men with prostate cancer is between 60 to 70 years of age. Prostate cancer is generally a disease of age. The older the man, the higher the chance of prostate cancer. However, in Black men, we begin to screen and look for prostate cancer from the age of 45. This is because we have some genetic predisposition to prostate cancer. There are certain mutations that occur more commonly in the Black race in genes that like the what we call the BRCA1 and BRCA2 gene, the RBC gene. These mutations occur more commonly in Black men. So usually from the age of 45, we begin to screen Black men for prostate cancer. But as I mentioned, the peak age that we find prostate cancer is somewhere between 60 to 70 years of age. This has been shown in numerous studies, including my own study. For my dissertation, I did studies for both of the colleges on prostate cancer. So we found, that the peak age is between 60 to 70 years of age. So usually why is important is that when a man that is 35 years old presents to you with some issues like difficulty with passing urine or blood in urine, prostate cancer doesn't come first in your differentials for your diagnosis. I mean, that would be very strange. But if such a patient is 60, 61 years old, he cannot pass urine or something, or there's blood in urine, low back pain, prostate cancer will definitely be number one. Is allowable if your diagnosis is not correct eventually, and you find out it's something else, than to be thinking of something more benign and it ends up being something cancerous like prostate cancer, which you could have picked with the index of suspicion early enough, and you may have been able to save that life. So that is as regards the age. Something else to mention is that the longer a man lives, the higher the chances that he may have prostate cancer in his life. As my boss will say, if you check 100 men, if you pick 100 men who are 80 years old, about 80% of them are likely to have prostate cancer. You pick 100 men who are 90 years old, about 90% of them are likely to have prostate cancer. If you pick 100 men who are 100 years old, all of them are likely to have some form of cancer in their prostate. But this does not now mean that is likely to be what is going to kill them. It can exist with the patient without actually being, sinister to the patient. The older a patient is when we make the diagnosis, the less worried we are and the less aggressive we are with the treatment.
Thank you very much, sir. Quickly, without wasting time, I'm going further again. Let's discuss those factors that could make a man come down. You've spoken about age. So let's try to talk about the area of family history. If a young man has a father or maybe a brother with prostate cancer, are there chances that he could come down with prostate cancer? What are those other factors that could make a man predisposed to prostate cancer?
So you said it perfectly. Age, number one, the older the man. Then two, we talked about genetics. So there's something we call a familial prostate cancer. So usually, if an individual has, prostate cancer occurring in 3 generations, grandfather, father, and then in their own. So we talk about a familial prostate cancer. If an individual has had a relative having diagnosis of prostate cancer less than 55 years old, that individual is likely, we're dealing with what we call a familial prostate cancer. I hope you understand what I mean. So what this means is that when somebody gives you such a history, you have to be a lot more aggressive in them, because familial prostate cancer occurs earlier at younger age. Those are the ones you can see as 40, 42 years of age. They are usually a lot more aggressive. What we call the Gleason score is usually a lot higher. So it spreads a lot faster and much more difficult to treat. And then mortality rates and survival is usually worse in this kind of patients. So when a man comes with this kind of history and you find out that his dad or grandfather or brother or somebody had that kind of disease, you must be worried. If you find out that somebody in his family or something contracted disease at an age younger than 55 years old, you should get worried. All right, so this is about familial prostate cancer. Other things will include things like obesity. Okay, it's said that obesity causes some hormonal imbalance because adipose tissues produce lots of estrogen, which is not the male hormone. So there's really a hormone imbalance, which is also one of the factors that has been said to be a predisposing factor to prostate cancer. Okay, great. All right, it said that deficiency of certain trace elements, things like zinc, selenium in diet, raise the incidence of prostate cancer. Many studies have been done to this effect, including studies that I've performed myself, and they have been found to a large extent to be true. Okay, we've talked about diet. That diet that is rich in fatty food and industrialized food can increase the risk of prostate cancer. Smoking has been found to be a risk factor for prostate cancer, just like every other cancer, 100 cancers, all of them. Smoking, if you say smoking, you're not wrong. They talk about the history of, we're going from more established risk factors to less established risk factors. Then some other risk factors are things like sexually transmitted infections. Some recent studies are showing that variants of herpes virus and viruses that can cause cancer in cervical cancer and co can cause recurrent inflammation in the prostate that can lead to dysplasia, metaplasia, and then cancer. All right. Okay, good. And then there are also factors related to when the part of the myths that we're about to discuss now, things that are related to stasis. So some researchers have also discussed the fact that patients who ejaculate more often, or individuals who ejaculate more often in the excess of 21 times in a month, have a less chance of developing prostate cancer than those who ejaculate 4 times or less per month. This was a study performed by Ryder et al. So these ones are things that are actually still under research and under review. So these are some of the risk factors. But as my boss will teach, will say, the first risk factor is being a male.
Yeah.
Being a male who has testicles, because if a boy is castrated at puberty, he can never develop any prostate disease, prostate cancer, or any kind of prostate enlargement. So it must be established that for a man to have the risk for prostate cancer or prostate disease, he must be a man who has his testicles intact and has normal hormone levels of testosterone in his body. Then these are things that can now occur or that we'll have to look out for. Thank you.
Thank you, sir. Before I hand over to Dr. Israel, please, I want us to touch briefly again on the last point you mentioned about ejaculation and prostate cancer. Now, the reason I'm saying this is because it's looking as if this is now confirmed medically, but you just mentioned that there are still research ongoing in this area, talking about ejaculating 21 times in a month and a man ejaculating 4 times in a month. I just wanted to briefly again emphasize on this because I hope to get a clip of this session and then to share it out. Are we saying that it's confirmed, or we still have research ongoing that if a man ejaculates about 21 times in a month, the chances of him coming down with prostate cancer is reduced because men will start using that as an excuse to start ejaculating every day?
Yeah, absolutely. It's not cast in stone and it's not confirmed. Because why I will say this is that there are also researches that have been performed which did not corroborate this finding, which found that there's no difference. Absolutely. And then you and I will agree that if this study is absolute, then what it will mean is that priests, clergymen, or those who engage in any form of celibacy all should have prostate cancer. But this is untrue. So research, is aimed at answering questions. And as a good researcher, your idea is to report exactly what you find. So Ryder et al. In their study did an excellent job because they actually followed up about 32,000 men in the Netherlands over years, looked at their sexual history, and looked at the incidence of prostate cancer in these men. They also looked at what, the grade and the aggressiveness of the disease that they had, over the years. And their study found that, men who engaged in higher number of sexual intercourse, they didn't talk about whether the intercourse or the ejaculation was from masturbation, from a single sexual partner, from multiple sexual partners. They didn't go into that. Was not their aim. Their aim was to identify whether there was a correlation between the number of ejaculations per month and the risk of developing prostate cancer in the future. And they found that those who ejaculated in excess of 21 times per month had a lower incidence of prostate cancer. They also found, however, that in those men, when they developed prostate cancer, it was usually a more aggressive variant of prostate cancer. Most people don't remember that when they are talking about that study. Okay, but as I said, there are other studies like Zhang et al., who didn't find any difference, in this group of patients. So this is still under investigation. This is still what we call under probable causes and things that are being, evaluated. Rather, a tall study tried to explain their findings based on what they call, the theory of stasis. And what they said was that, when we eat and drink and are exposed to various things in our environment, the body produces fluids, they produce different things. The prostate itself produces what we call prostatic fluid. Prostatic fluid accounts for about 20%, 25% of the ejaculate. So it's believed that men who ejaculate more frequently have little waiting time between production of the prostatic fluid and ejaculation, while those who may not ejaculate that often, have the prostatic fluid being there in the prostate gland for a lot longer. Therefore, there is higher interaction, especially for those who, interact or ingest carcinogens, industrialized substances. So some of these carcinogens may have longer time to, interact with the prostatic epithelium, and this could predispose them, to high incidence of prostate cancer. But as I said, these things are still under evaluation, and I think everybody should take them with a pinch of salt. But most importantly, everybody should live healthy.
Thank you very much, Dr. Martins. For my people, open I don't hear, because when I put this thing on my status, the first thing when somebody sent to me was that they say somebody when they have sex every day in a month, not they get prostate cancer. I just laugh. And today, Dr. Martins have actually tried to clear that aspect. So, Dr. Martins, thank you so much. If Jody join us, we see they talk about prostate cancer. So the next question we want to ask is, sir, what are the symptoms, the signs and symptoms somebody will see before he can be thinking this may be prostate cancer?
Thank you, Dr. Israel. Nice to have you. So number one is that you must realize that the patients can be asymptomatic. It means that they can have prostate cancer without knowing. Ideally, this is the type of patient that you want to see. Somebody who just walks into the clinic, a 50 or 43, 46-year-old man, just wants to have screening. Oh, doctor, I'm coming here for my annual screening for prostate cancer. You talk to him, no symptoms. You run his blood check, his PSA check, you examine his prostate, and ultrasound if need be. So patients can be asymptomatic. We must bear that in mind. Then patients could have what we call local symptoms. That means symptoms that are related to the prostate. Prostate cancer can cause the prostate to enlarge. So this can cause some form of obstruction to the flow of urine. So the man can have difficulty with passing urine. He may have to strain before urine comes out. When it comes out, the stream may be poor. He may see some blood in his urine. He may have to wake up many times to pee at night. And even during the day, within a short time, he wants to pee again, and he wants to pee again. Sometimes he can't hold urine. If he doesn't go to pass urine, he may pee on his body. These are lower urinary tract symptoms, which can be a signal that they may be prostate cancer. They can have what we call local evidence of local advancement. This is the prostate cancer is spreading to structures that are around it. During ejaculation, there may be blood in the ejaculate. We call that hematospermia. He may begin to have things like constipation because the prostate is just in front of where the rectum is. So it can begin to obstruct, feces and things like that. He may have symptoms related to what we call metastasis, when the prostate cancer spreads to the common places it likes to spread. The commonest place it goes to is the lower back, the lumbar, and the sacral vertebrae. Low back pains, bone pains, set on the long bones like the arm, the legs. The low back pain can begin to affect the nerves that emanate from the spinal cord. And it can also cause the vertebrae to collapse on each other and compress the spinal cord. So you can have weakness of the legs, inability to walk, inability to control urine and feces, etc. We have seen in our study, if you look online on unusual presentation of prostate cancer, you see a study that I performed along with my teachers where we looked at the unusual ways that they can also present, with lumps on the head, on the bones, and things like that. But I mean, it's good to know the most common things, like the things that we've discussed now. So these are the ways that patients can present with prostate cancer.
Thank you, sir. If I may add quickly, sir, to what Dr. Israel asked, what would be the time frame? So let's say a man was not aware that he had prostate cancer. How long would it take before he begins to develop symptoms? Do we have any time frame with regards to the symptoms of prostate cancer?
So that would depend on the age of the patient, the aggressiveness of the disease, the variant of the disease. So as I mentioned, the older the patient, the less aggressive. So this is why a man that may be 90 years of age may have absolutely no symptoms. And he may have prostate cancer, while a patient who is a lot younger, in his 50s, may just take a year, less than a year, and the cancer is aggressive and progressing. So usually it depends on the variant, we call it the histological variant. A more aggressive disease will take a shorter time to manifest. A less aggressive disease is indolent, it's just there and rarely just slowly spreading, just slowly growing. So this is why there's no age that you say, oh. But what we must say is that, for instance, there are ways that we monitor or evaluate patients when we are not sure. So usually, like the PSA, when the PSA doubles in less than 6 months, your worry or your index of suspicion for prostate cancer goes very high. So what this means is that for the younger patients, usually within 6 months to 1 year, patients may begin to have these symptoms for the younger age group. Between 40s to 60, early, 40 to 60 years of age. So there's no specific age group, but as I mentioned, the younger the patient, the more aggressive.
Thank you very much. If you are just coming, you are welcome. We are talking about prostate cancer, and we have Dr. Martin Sibokwe. You can see his name on the screen. He works in Abuja, the Zenith Medical and Kidney Center. He's a transplant surgeon, a kidney transplant surgeon, and he has been talking to us about prostate cancer. Quickly, sir. Now a man has prostate cancer, or maybe he has it but with no symptoms. How can we arrive at a diagnosis? Please help us share this live session. How would yourself, let's say a man presents to you with prostate cancer, how would the process go? Like, somebody is scared, is wondering, when I go to the hospital, this is what they will do to me. I don't know what they will do to me. So could you help us break down the steps? Okay, Dr. Martins is busy. Okay.
I'm with you.
Yes.
Yeah.
Yes, sir.
So when a man presents
sorry,
to
sir.
the clinic,
Sorry, sir. Somebody's asking a question. I think it's important here. He's saying, what is PSA? So as you're discussing, sir.
PSA is a short form for prostate specific antigen. It's a tumor marker. It's a blood test. Is a blood test that we do for patients when we are screening or monitoring them or evaluating them for prostate cancer. We take a little blood sample and send to the laboratory. So the PSA is that blood test tells us whether we should be concerned or worry about prostate cancer. So usually it should have a value of between 0 to 4 nanograms per ml. But when we see values greater than 4 nanograms per ml, it increases our worry or our concern, for prostate cancer. So great. So you asked, when the patient comes to the clinic, what do we do?
Yes, sir.
So when a patient comes and we evaluate, we take a history, ask, how he's doing, what the age, the symptoms, like we asked. We ask about the family history. Are there members of the family that have had disease like this? Are you having difficulty with passing urine, blood in urine, things like this? We ask all this history, back pains, are you able to walk, all those things. When we are done, the next thing we want to do is examination from head to toe. We may have said a few things here, but I want you to realize that any disease condition, including prostate cancer, can have manifestations from head to toe. What do I mean? Prostate cancer in the advanced stage can actually grow to the extent that it can actually affect or obstruct the ureters. Those are the tubes that carry urine from the kidneys. When this occurs, patient can have renal failure. They can have recurrent kidney infections, etc. So what I'm trying to say is that from head to toe, you can evaluate them. From patients who lack blood, if they've been sick for a long time, if they've been passing blood in their urine, if their bones, if they already have cancer spread to their bones and affects production of blood, all right, they could look malnourished. You could see evidence of spread of cancer to the bones, to the ribs, anywhere. But the specific examinations for prostate cancer will be in the abdomen and in the pelvis. In the abdomen, we want to check if this person is passing urine. Sometimes it can come what we call urinary retention. You notice that the bladder is full and distended. Okay, because they can't pass urine, the prostate has obstructed where urine flows from. All right. They can also have evidence of infection in their kidneys, especially if urine is not flowing and urine is stagnating in the kidneys. We also check their back for back pains that may show that they have spread of the cancer to the bones of the spine, which is the most common place that it spreads to. And then, very importantly, we also want to check, do what we call a rectal examination, where we stick a finger into the rectum to feel the prostate gland. Usually, this helps us go a long way in making this diagnosis. In prostate cancer, we expect the prostate to be enlarged, to be hard and nodular, just like a rock. Unlike in the normal person where it's smooth, it's firm, and feels just like when you press the tip of your nose. So what we used to say in training is, when you feel your nose, this is how the prostate should feel. When you feel your forehead, this is how cancer will feel. So normal prostate, cancerous prostate. So when you feel the prostate gland, you look for the texture of the prostate, the nodularity, and things like that. Whether one of the lobes of the prostate is bigger than the other, and things like this. So this will go a long way in telling us whether there's cancer or not. Many times, by the time I'm done with the examination, I can almost tell whether the patient has cancer or not, especially if it's an advanced prostate cancer. In our environment, 80 to 90% of our patients present in advanced stage because we don't have a good health-seeking behavior in Nigeria. We don't have a good screening mechanism for prostate cancer because patients have to pay out of pocket because there's a lot of ignorance as regards prostate cancer. And this is the more reason why we're having this kind of talk. So many times at this level, you can really tell. There are people at this level I've told that, sir, from your history, from examining you, the diagnosis that we have here is most likely prostate cancer. However, we are not God, so we are still going to run some further tests on you to be sure. But you start preparing their minds. That goes a long way in reassuring them and letting them know that these people know what they are doing. They have an idea of what the diagnosis may be, but let's confirm with the tests. So eventually, when the tests come out, their minds are prepared for the diagnosis. So afterwards, then we go to run blood tests. All the regular blood tests, from the full blood count, the kidney function tests, urine tests, etc. We must do the PSA, just like I mentioned, the prostate-specific antigen. It gives us a good index of what is going on. Many times in our practice, you see patients with PSAs of 200, 1,000, 2,000. By the time you are seeing these ones, it's not just that it's prostate cancer, but it's most likely you are dealing with a metastatic or advanced disease. Okay? Then we run ultrasound scans on the prostate gland. Imaging, we can also do the best imaging modality for staging for prostate cancer is what we call an MRI, a prostate MRI. This test will evaluate the gland properly and tell you, is there cancer? Is there suspicious area that looks like cancer in the prostate gland? Has it gone beyond the gland? Are there lymph nodes? So this helps us for staging, local staging of the cancer, you know, and things like that. All right. Other things will be to check whether it has spread. X-ray of the back, X-ray of the lung bones, what we call a PET scan, a PET CT scan. This is a scan that is done like a whole body test, checking all the bones and everywhere, whether there are evidence of cancer spreading there. By the time you have done all these tests, you have a good idea of what's going on. Then we do what we call a prostate biopsy. It's a procedure whereby we take the patient to the theater, minimal anesthesia, and use a small needle that looks like this to take some specimens from the prostate gland. It's painless. We give some anesthesia so the guy doesn't feel any pain. Through his anus, we take some tissues from the prostate gland and send to the laboratory. Only then can they confirm that he has prostate cancer. To make a diagnosis of prostate cancer, you need what we call histology, a tissue diagnosis. Some part of the prostate tissue must be taken to the pathologist, who must look at it and confirm that it's prostate cancer. Along with the confirmation, they also tell us what type of cancer it is, how aggressive is it. Is it adenocarcinoma, which is the commonest in about 95% of the cases, or is it other rarer forms of prostate cancer? What's the Gleason score? Is it the type that will spread fast and kill, or is it an indolent one that will go slow? Is there evidence of invasion into the vessels, or we call it neurovascular spread, etc. When we have done all this, then we sit down again with the patient to counsel, along with a relative. I don't like to do this alone. The wife must be there, or the son. Somebody must be there while we are having a talk. This is what we have found so far. Based on the stage of disease that you have, which is stage 1, stage 2, stage 3, stage 4, as the case may be, the aim of your management is this. If it's an early cancer, we can do this to cure. If it's an advanced one, we can do this to keep you alive for as long as possible. Things like that. So this is the way it goes in my clinic.
Thank you very much, sir. You've told us a lot today, a lot, and we are really grateful. So before if you are joining us, we still talk on prostate cancer. I beg Mona, try share the life. It is very important. Share the life so that other people will gain what you are gaining. It's not easy to break consultant to come follow una talk and tell us things about prostate cancer. Sir, please, can you help us and tell us how we go fit to prevent this cancer? Is there a way we can prevent prostate cancer?
Yeah, so as for every disease condition, prevention is better and cheaper than cure. Okay. Unfortunately, for cancer, I'm sure as we are doctors here, we know that really we don't really know what causes cancer. To be honest, that's why we talk about risk factors. This is because if you check 100 patients who come with cancer of any part of the body, you're going to find out that about 80 to 90% of them don't even have any of the risk factors we are speaking about. I don't know that you've noticed it in your practice. When you talk about breast cancer, you notice that the women, they are breastfeeding, they have children, they have, so all the risk factors we talk about are what studies have shown. But deep down inside, most cancers, we really do not know how it comes about. So, but that being said, specific for prostate cancer, we can say that one, it's important to know if you have a family history of prostate cancer or not. For those who have a family history of prostate cancer, then it's more imperative that they have a lifestyle that goes a long way in preventing and reducing the risk of prostate cancer. So this is very important for them. If you are a Black man like we are, where we know that we have a high incidence of prostate cancer than other races, this is also for us. Not only do we have a high incidence of prostate cancer, we also have a more aggressive disease than other races, like the whites, the Hispanics. The Asians have the lowest risk. All right. So what are those things? One, diet. It's important to ensure that you have a diet that is rich in fruits and vegetables, along with things that contain those trace elements that we mentioned, like selenium, like zinc. It's important that your diet is low on fatty foods, is low on animal proteins. Number 2, prevention of obesity by exercise. Staying fit can never be wrong. When your BMI is within normal, when your weight is within normal for your height, it reduces the risk of obesity. And we've spoken about obesity being a risk factor for prostate cancer. We talked about cigarette smoking. These are the things that should be avoided completely. All right. We've talked about the risk factors that we talk about, things like STIs, especially HPV, certain variants of HPV, that's human papilloma virus. So what it means is that sexual intercourse must be protected or with your trusted partner. All right. Most importantly, because we know we talk about primary prevention, secondary and tertiary prevention. Most importantly, for those of us that now have this risk, despite having all these lifestyle changes to keep ourselves okay, it's important that as from 45 years of age, you should voluntarily just walk into the hospital to see your urologist to ensure that you're screened, so that peradventure any time in the future, 10, 15 years after then, you notice your PSA is getting more, higher than normal, you begin to look deeper. This helps you so that if you even develop prostate cancer, which by God's grace you won't, is picked up at the earliest stage, at which point curative treatment can be offered and you can forget that you ever had the disease. Okay? And for tertiary prevention, this is for people who already have the disease. Ensure you seek care from the specialists. We find out that in our environment, most people will go to the church, they go to the mosque, they go to chemists, they spend some spend years, months to years in these places. And by the time they present to you, they are presenting at a stage 4, at which point all you can do is palliative care, just to prolong their life for a couple of months before they die. So there are various levels to prevention: primary prevention, secondary prevention, and tertiary prevention. Thank you, Dr. Israel.
Thank you, sir. If you are just joining us, you're welcome. We're talking about prostate cancer with Dr. Martin Zimbokwe, and correcting some lies, the lies about prostate cancer. If you have any questions on this topic, please start dropping your questions so that we can ask Dr. Martins, and I'm sure he'll be glad to respond to you. So quickly, with regards to the treatment, somebody will want to ask, can prostate cancer be cured? The next question with regards to the treatment is, if it can be cured, can a man live his normal life without being scared, even if he has prostate cancer?
Okay, yeah. So for early disease, by early disease, we mean when prostate cancer is confined to the prostate gland, when it has not gone beyond the prostate gland, it can be cured. Absolutely. So there are many factors that we consider before we try to offer cure. So cure, there are 2 established modalities for cure. Surgery, what we call radical prostatectomy. We perform this surgery routinely in Nigeria now, in my center, and in centers all over the country. Okay, it's a big operation. I'm going to talk a little bit about that. Then the other established treatment is radical radiotherapy, where we use radiation to shine on the prostate gland and kill all the cancer cells. These 2 are established treatment modalities for early prostate cancer. There are other modalities that are not established. I'm being cautious with my words because I know abroad in some places they do cryotherapy, ablation with ultrasound waves and things like that. But I'm talking about mainstream, what we do, what is done everywhere in the world. I mean, not things that are still under trials and things like that. So which of them we do for patients is based on many things. One, we look at the performance status of the patient. How healthy is this patient? Is this somebody that is in 80s or 90s? Why the hell would you want to do such big operation for such patient? The effect of your surgery can even, worsen the guy's quality of life. Do you get me? So you're looking at the age, how fit is this person for treatment? All right. What facilities do you have on ground where you are? What skills and expertise do you have on ground where you are? How aggressive is the cancer? And then what are the patient's expectations? This is very important because when you are going to offer radical surgery for prostate cancer, there are two important complications that the patient must be ready to live with if they occur. Number one is what we call erectile dysfunction. The nerves that supply the penis to make it to stand, to be erect when you want to have sex, run at the side of the prostate gland. So many times prostate cancer invades these nerves and destroys them. So the guy doesn't have erection ab initio when he meets you. But in some patients, it may not have gotten there. Your surgery, you have a chance of injuring those nerves. So a patient can have erectile dysfunction after prostate cancer. The more, the better a surgeon is at the surgery, the more gadgets he has during the operation, the more meticulous, the lesser the chances of having this complication. But it's something that is established as a common complication that can occur in prostate cancer surgery. Number two, urinary incontinence. This means inability to control your urine dripping on its own without you able to control it. Because when we take out the prostate gland during prostate cancer surgery, we have to cut the prostate gland completely and reconstruct the bladder neck with the urethra, the tube that carries urine out. We have to because the prostate is in between the bladder and the urethra. So we cut it off completely and then we have to restitch them together. So the area where we do this stitching, we have to narrow it in a way that that prevents urine from leaking. Otherwise, the patient can have urinary incontinence. So you have to counsel them about urinary incontinence. The good news is that expert surgeons who have done this surgery many times, the chances of having urinary incontinence reduces. Usually by 1 year, about 95% of patients will no longer be leaking any form of urine. In my practice, in about 6 of these surgeries that we've done, none of them had this kind of complication beyond 1 month. But I've seen many more patients that have had the surgery, both abroad, robotic, etc. And I know it's a common complication. Many of them have to wear diapers for up to a year, 6 months to a year. So if you don't counsel the patient on this complication, then you have no business performing radical prostate cancer surgery on them. However, why our patients still have these surgeries, that you have to tell them, so sir, the options are clear. It's either we continue to palliate the disease, which may kill you, or we offer you this curative care. However, you may have so complications. So it's something to discuss with your family, discuss with your wife. If you have erectile dysfunction, is she ready to live with it? There are also cures, or there are things we can do for erectile dysfunction. Or it's not that we can't cure it, or there are things we can do for you to have erection, but it may also require surgery and some other forms of therapy. You may not be able to control your urine, or your urine may be leaking. It occurs in about 10% of patients after a year. But if it persists, there's also some kind of therapy and surgery that we may give you to keep you dry. But you must be aware of this before you even decide to come for the operation. Many people will tell you at this stage that, no, I'm not interested. It's rather I die. It's better I die with my erection than not having an erection. You know, the black man, we don't play with our erection at all. So this has to be very clear. The radiotherapy as well causes these complications, but to a much lesser extent. And usually after the radiation, in few weeks to months, patients begin to recover. So, but you know, it's give or take. The important thing is that you counsel patients adequately so that the choice is made, you know, an informed decision is taken based on their peculiarities.
Thank you very much. We have some questions here, and I hope we can take them, sir. So, Dr. Martins has addressed the first one. He says, is there a way to prevent? He addressed prevention. And you are asking us for drugs. Sorry, we don't discuss drugs here. I'm sorry. This person is asking us, where can we do the test for, I believe, for the prostate specific antigen? Where can we?
Any laboratory around you, any good laboratory should run this kind of tests. Any laboratory. I mean, if you don't trust the laboratory, you can go to any standard hospital, a teaching hospital, an FMC around you. I'm sure they run this. Is a routine test that can be performed anywhere.
Can be performed anywhere. We have the next one. Can nutritional supplements like chelated zinc prevent prostate cancer, and what are the diets that contains zinc?
So what I tell my patients, usually, if you have a good diet, you don't need to take supplements. Supplements are taken when people are, there are two things that make patients to take supplements. Number one is if you have an increased demand for a particular nutrient. For instance, you're an athlete or you're into some form of physical activity that makes you to require, because you burn so much calorie, you use lots of your nutrients, so you need you need rapid replacement because you can't get enough of it in your diet. Yes, that's one. And then number two is if you have a poor dietary intake or you are sick. Otherwise, if you eat a normal diet rich in fruits and vegetables, zinc, for instance, is contained a lot in vegetables. Your ugu, your efo, your salads contain high levels of zinc, carrot, cabbage, all those things naturally. So if you're in the habit of taking lots of fruits and vegetables in your diet, then you're likely not to require any supplements, to prevent any of these diseases.
Thank you, sir. This question, please, doctor, if you happen to have options, will that person still be okay? If you happen to have, I believe, operation, I don't know if this is what you're asking. I don't really understand this question.
Yeah, if his operation is talking about, the patient is going to be okay. Once it's performed, in expert hands, patient is going to be okay. They are fine. They come to the clinic, they greet you, they bring presents for you, they see you, every 3 months, happy. Most of my patients, if not all, who have had surgery for prostate cancer are happy. I can tell you that for him. And that happiness also comes with one thing: counseling. Because first things first is that they must even understand what they had in the first place. So this also comes with, I would say, education. Very educated patients who know what they had. So when they're offered the care, they know exactly what they've gotten. They know exactly what they've escaped. And they're looking at a different life ahead. And they live for so many more years. It's like taking them back to what they used to be before the cancer. So usually if you're lucky and there are no complications, or the complications are minimal and they can live with them, then absolutely, they're fine.
Okay, if you are just coming and you are asking us any question that we've addressed before, sorry, we might not take your question. Okay, so Brighton also is asking, please, can an inflammatory disease, this word, you guys keep like listening to word, such as Staph aureus, that causes frequent urination, be the cause of prostate cancer?
Okay, so let's start with the first thing. Once you hear Staphylococcus aureus, just know that the person is not a qualified doctor. Once you hear that, all these things that you hear, oh, you have Staphylococcus aureus, just know he's a quack. Let's just start from there. I mean, because because when you hear it, as in that's one of the ways I tell whether to listen to somebody. Once you hear the person, it has staph, I don't just bother listening, because it means this person didn't study medicine or studied on the streets or quackery and all that. So for the people that are listening here, it's important that you get your medical advice from a trained medical personnel. Let's not go into the fact that not even all medical personnel are up to scratch. The truth is that, if you study medicine, then obviously you need to also continue to educate yourself and continue to change with the trend of things that occur, in practice, right?
Yeah.
So urinary tract infections, if you see Staphylococcus aureus cause urinary tract infection, you should look, because that is so unusual. When you see Staph aureus, what it tells you is that the individual did not submit the urine sample properly. He used the bottle to touch his penis. Or in women, it's so common because women, it's so hard for them to have a clean catch of urine.
Mm-hmm.
If you've ever seen a woman trying to submit a sample, it's very cumbersome sometimes. having to put the bottle in between their legs and touching. So ideally, that bottle should just be in the air, and just the urine, you should pee into it in the air. If you touch it with your hands or with your penis, your glans penis, then you're going to see Staph aureus, because Staph aureus is a normal flora on the skin. If you take a swab of my skin now, Staph aureus is going to be there. It's never expected to cause any disease condition unless there's a problem. So, for instance, if you have a breach, if you have a cut on your skin, then Staph can actually cause an infection, of that wound, yes. But in the UTI, very unusual, unless there's a big problem, patient is immunosuppressed, etc. So, but let's go to your question. Recurrent inflammatory conditions of the prostate gland is one of the risk factors that some studies have shown. So they affiliate that with things like chlamydia, gonorrhea, HPV, as I mentioned earlier. It's been said that if they cause recurrent inflammation in the prostate over years, then it can begin to cause changes in the cells like metaplasia, dysplasia, and that can lead to cancer formation. This is also one of the risk factors that some authorities have put forward.
We have a question here. Okay, we have this quickly. We are almost out of time. Please, doctor, what about the operation? You will have more. Oh my God, sir, do you understand
Pain.
this? Will you have more pain? What will you do? I don't get your comment, Helen.
No, but let's try to help Helen. Of course,
Okay.
surgery now, usually there's pain after surgery because you're going to be cut. This operation can be performed open, where we cut your tummy, sorry, not your tummy, because Helen is even a woman, where we
woman,
cut the tummy of the man open, a nice cut, small cut, and do the operation. Or it can be done minimal access, where cameras are used. This can be done as laparoscopy or robotic. This is done. Laparoscopy is not very much established in Nigeria at the moment. We only have a couple of people who train abroad who come to do this kind of operation here. Robotic, we don't have a robot in the whole of West Africa. So, but this is offered routinely in India, in America, etc., etc. Here we do open radical prostatectomy. So there may be pain after surgery, yes, but part of our job is also to ensure the patient is pain-free. So we give good amount of pain medications in the initial stages, because after the initial stage, when the wounds and everything heal, then there's no pain, absolutely no pain.
Okay, quickly. Can it stop one from impregnating a woman? And if the man can impregnate, will it affect the baby?
It's talking about the prostate cancer itself.
Yeah.
Yes. So as I mentioned earlier, the age group of people that have prostate cancer are not the type of people that are looking for who to impregnate, because it's common in the elderly patients. If a man still wants to be impregnating women, then it's not the right thing to come for this kind of surgeries, because the radical surgeries we are doing for prostate cancer, part of their aim is to remove the prostate gland with the seminal vesicles, so it will not allow sperm to come through the normal way to impregnate a woman. So if a man is still looking to impregnate people, then he will not come for this kind of surgery.
So there's this question I want to ask, and it pertains to social media. Now, I have seen on Facebook majorly prostate cancer herbs. If you drink this herb, it will cure prostate cancer. If you drink this root, it will cure prostate cancer. Please, in your experience, and with research, I don't know if you have come across any. Help us throw light on this. Is it possible? Do we have any medical backing with regards to this?
No, but what I'll say is that the people that take the herbs are the best to tell you. But I can tell you that you're on your own. I mean, it's just a waste of time, because the first thing is, what I tell patients is this. In medicine, we don't go, we don't advertise, so you're not allowed to go and start, go to the parks, ringing bell, giving them something to drink. But what I tell these people is, if a herb that they're going to give you is going to cure prostate cancer, they're not talking about the stage, the histology, whatever. It will cure pile, it will help your erection, it will help, your diabetes, your hypertension. Doesn't it tell you that that's fraud? Because the etiology to all these diseases are completely different. So what I would advise our people is, I'm sure that there are hospitals anywhere close to you, and I'm sure that there are specialists that you can find. It's better you put your health in the hands of people who have been trained, to treat you and to manage you. These people you can hold responsible if you are not, if you don't get the best care. It will be difficult for you to go to an Instagram herbal vendor to tell him that you gave me drug for prostate cancer, but I'm dead. He doesn't have a certificate. He's not trained. In fact, you feel foolish even calling that person out because this person never told you that they knew what was wrong with you. They were selling a product and you bought it. So put your life, in the hands of people who have been trained to treat you and to treat that condition. I think that's the best way to hold yourself and to hold them accountable.
Thank you, sir. As we round up tonight, what will be your advice, sir, for young men, presumably healthy young men, not here with prostate cancer? What would you want to advise them, sir, as we round up?
I want to say that one, I'm so happy that you're listening, to this live session. Number two is to ensure that you know that prostate cancer is the commonest cancer among Black men and the commonest cause of cancer-related death among Black men. This information is for you and for your dad, your uncles, your brothers, anybody around you. It's important that we realize that it's good to live healthy in order to prevent ourselves from developing prostate cancer in the future by eating healthy. I mean, lots of fruits and vegetables, reducing our ingestion of fatty foods, industrialized foods, red meat, etc., and more of fruits and vegetables. It's important that we exercise to stay fit. It's important that we avoid ourselves from being obese, from smoking, taking alcohol, and all sorts of things. It's important that we have a good sexual, healthy sexual life. Prevent ourselves from sleeping around unprotected, etc., and have one partner, and stuff like that. And then, most importantly, it's important that we have a good health-seeking behavior. What this means is that once we are 45 years of age, it's important that we try to go to see a urologist at least once every year to have our annual checkups, have our PSA checked, have our prostate examined, have an ultrasound scan done on us so that we ensure that we stay prostate cancer free for the rest of our lives. Thank you.
Thank you very much.
Thank you very much, sir.
Sir. Dr. Israel, you have anything to add?
We really appreciate. For me, we see many questions. So for all these people, all these things, our guest, Dr. Martins, a consultant urologist, he don't talk all these things. So if you are just joining us, I beg, after the live, you feel just watch the replay, and you will get everything, and the questions that was asked and the answers that was given. Then if you novice, if you can't ask question on that, we not go fit answer them because it don't pass. So more than novice, now maybe they say the time at 8 p.m. Try come 8 p.m. so that you will not miss anything. I want to say a very big thank you to all of you now who join us today. You guys are wonderful.
Finally, sir, is there any way?
You, Dr. Martins, you have done well.
Someone wants to
thank
get
you
in
so
touch
much.
with you, sir. I know you are in Abuja, the Zenith Medical and Kidney Center. If someone wants to get in touch with you, how?
my social media handles are there. I'm on Instagram as Dr. Martin Urology. I'm on Twitter, Dr. Martin Urology, Facebook. I'm everywhere. So you just send me a DM. If I have the time, I usually find time to answer or refer appropriately. What I do basically is that for patients that have symptoms, because I have, well, maybe we're about 250, 300 urologists in Nigeria. We all seem to know each other. So it's usually easy for me to point you to the closest urologist I can identify in your area, in Lagos, in the Southeast, everywhere. It's just like a small family. So because most things, a standard urologist should be able to manage most of this. We are very comfortable managing most of this. Things like prostate cancer, this is like the commonest cancer that we see in our clinic. So any trained urologist in Nigeria should be comfortable managing prostate cancer. So if you reach me, I can always direct you to someone that is around you who can manage, your condition.
We sincerely appreciate you, Dr. Martin Sibokwe, for taking out your time to join us today. We don't take this for granted at all. Thank you once again, sir. Thank you.
All right, Dr. Fred, thank you very much. It was nice to be here. Bye-bye.
Thank you so much, sir.
Thank you, sir. Bye-bye, sir. Ladies and gentlemen, thank you once again. For those that came late, no vex. We know if you take your question, like Dr. Israel said, you will have to watch the video again. This program is every Sunday, 8 p.m. on the dot. We get starts. 9:05 we shut down. We know they won't waste time here, so no vex. Go again and watch the video, and you will gain everything. Dr. Israel, any words from you as we go?
I think I don't talk with I want to talk when I do well. When I'm not versing a correct English our guy use, now me can be your guy. And you'll notice and you'll notice say sometimes that they try put small of our normal English where we say we they use for here. So
we
but
know tell
all
say,
the same and we not tell them all the same, I believe you guys understand, and when again you gain one or two things from the video. So when I hear the prevention, it is very important. You see, say the prevention are almost the same thing for almost everything. Exercise, eating vegetable, run from this, run from that. You know, just almost the same thing from almost everything. And also for we when be young men, Dr. Fred, myself, and every other young man when they here. I beg, once we don't reach 45, make we see try. Make we they remember ourselves. Say once we don't go that age, make we they try to do our screening at least once a year. So that if anything, you see, for the first stage of prostate cancer is curable, they go fit cure am. But when it don't pass that first stage, anything can happen. So let's be maybe they quick go hospital so that we can get the best. Thank you for everybody that joined us. Thank you, Sophia. Favor that joined from my side. Thank you so much. And every other persons we join. And well done.
Mr. Alex Ogua, thank you for the 100 stars. Thank you very much. I won't beg us. I beg everybody when they watch this video, share this live. Just share them.
Very important.
No be every time make we they do they talk about Bobby, they talk about Nyash, Angola on social media. People need this information. I beg. It cost us as they beg our guys to come here. Make una support us by sharing this video. God bless you. Like I always
talk. We not say you give us money now. Just share them.
Just share. I beg. Thank you. Remember, good life.
Nah sense.
Good life. Nah sense. Take care and have a wonderful day. Bye-bye, everybody.